I've known Dennis since 1990, when we transferred him from Fieldhead Hospital to come to live at Oxfield Court. He's quite an independent person in some respects because he can tell you exactly what he wants. You know his likes and his dislikes. He indicates those even though he can't communicate orally.
Dennis is a strong character, so he's got his likes and his dislikes, and he knows who he likes and he knows who he doesn't like, and he can't take offence to it because it's his personality. So, for instance, if I was on shift when I worked at Oxfield Court, if a favourite member of staff would be on, he wouldn't speak to me. So I wouldn't have any eye contact, he wouldn't eat lunch from me. But then on another day you might be on and you might be his favourite member of staff, and that's Dennis.
There's a few residents that he really does like. You've met one today, Denise, and they sit very close together and she keeps an eye out on him.
I look after him every night time. He's a good friend.
He's just happy. He's relaxed, and he's obviously comfortable. He doesn't show any outward signs of being distressed when he's around his friends.
With the home staff, he goes out on day trips, so shopping for new clothes, for music, buy his Mother's Day presents, goes out for meals, goes on holiday.
He likes to go out for a coffee. Special occasions we meet up with his mum. So Cara will take him out and meet up with Mrs. Burt, and they go out for a meal together. We during the summer when it's warmer, we do picnics and just trips out generally.
He'd be a rocker. He absolutely adores rock music, so Bon Jovi, that type of music. If he got that going, he nearly tipped his wheelchair over. And so all the staff would always say, Dennis would be a rocker. I wasn't actually around when Dennis came in hospital, so I found out about the event afterwards. But my understanding is that he choked on some chicken and aspirated and then had a seizure. So that's what led him to come into hospital via ambulance.
I was called at about 1:20 in the morning and came straight there because they said his situation was very, very critical. And at that point we called his family as well.
He was with us for a couple of days but responded really well to IV antibiotics, IV fluids and oxygen. And then I got the call from Marnie when I came back to work telling me that the Do Not Attempt CPR form had come over with the ambulance staff in an envelope. Which
I was just left in shock really, because at no point had I been informed that Dennis had been put on a Do Not Attempt CPR form, and I was just blown away really.
Well, when I took the phone call from Marnie, I was just devastated. I just basically thought it meant that they weren't going to help him at all if he become ill again. I just envisaged him having a seizure after seizure and just being left.
The form had been done on the day of his admission and obviously hadn't been reviewed on his discharge, so I was left with an order that's in place that's, it's a legal document. It had also stated that the reasons, for not doing the DNR, which the terminology I didn't think was appropriate, just because somebody's got a learning disability and a poor quality of life, apparently, does not give you a reason not to resuscitate, not in my opinion.
During the course of his life, just like all of us, we all find our own pleasures as we grow, and we find the things what interest us and what we get enjoyment out of, and Dennis has just done the same thing. He's made the best of what he's got.
Yes, Dennis might not do what me or you do on a daily basis, but he has his own routine, he has his own preferences, he has his own likes and dislikes, and that He can't tell you that, but his carer could.
Somebody just saying that a person hasn't got a quality of life, I just don't see how they have the right to say that, especially when they don't know him.
Not only was family cross, but so were staff who worked at Oxfield Court. They were quite upset about the form. And I think it's quite sad, really, because once you understand the reasons behind the form, you have a good understanding. So if those conversations had taken place with family and carers, it could have completely been avoided. But also, if they'd have used the fact that he had a poor swallow, high risk of aspiration, high risk of chest infections, and he had epilepsy, people would have understood that. But because they used poor quality of life and learning disability, it was like two stabs, if you like. It was one, that the form had been filled in and they hadn't been consulted, but two, that they'd put those labels on the form, and that's what they found quite upsetting. When medical staff are considering a do not attempt CPR order, it is their decision. It is a medical decision, but best practice is that you communicate with the family, with the patient and the family, about that, what you're thinking, why you're thinking about filling one of those forms in, what that form means. And I think there is a misconception that do not attempt CPR means that we will not give any treatment, and it doesn't. You still will receive full and active treatment. It just means that if you have a cardiac arrest or your heart stops, that you will not be having CPR.
I think when we come to talking about DNA CPR decisions, it's very important to look first of all what CPR actually is, because I think if doctors and families have a better understanding of that, then they can come to shared goals much more clearly. It's important to remember that probably only 2 out of every 10 patients who undergo a cardiac arrest will actually live and survive that event and make their way home from hospital. I think a lot of the lay public maybe don't understand that. There'll be a large group of patients for whom it's anticipated that they will not survive that aggressive treatment, and it would therefore be appropriate to make a decision in advance. And I suppose that's where it's difficult for doctors. Doctors are trained to treat, we're trained to do things, we're trained to make people better. But I suppose when we're talking about a situation where maybe the patient will die, it is hard for doctors to start to have that conversation. Part of what happened in this case, that a decision was made from best practice, from good principles, but they didn't communicate. And also their rationale in making a decision wasn't as factual as it could have been. It's very easy, I think, for health professionals to assume that someone with a particular condition or learning disability has a poor quality of life because it's not the same as theirs. But we can't make those sort of value judgments. Well, there are several main areas of, if you like, legislation. Aside from the cardiopulmonary resuscitation issue, the Mental Capacity Act of 2005 is there to protect patients, but also to guide clinical staff. We assume that patients have capacity to communicate, to make decisions regarding healthcare choices. It could be said that perhaps Dennis lacked full capacity, but if he's not able to communicate with us or with the clinical team, then it's behoven on the clinical team to involve the lay carers or other professional carers who may be involved in Dennis's care. It comes back to whatever decisions are made, they're made in his best interests. And so there's a consensus opinion that's agreed. So the Mental Capacity Act underpins a lot of what we do. Specifically relating to cardiopulmonary resuscitation, there's a lot of guidance, the joint guidance from the Resus Council and the BMA and the Royal College of Nursing give a lot of guidance on how we make those decisions and how we communicate to patients and their families. Likewise, the recent publication from NCPOD looking at the care around cardiopulmonary resuscitation has recommended that when patients are acutely admitted to hospital, a resuscitation decision must be made within 24 hours of admission. And that's where the decisions relating to how aggressive, how much will we escalate this treatment, what's the patient's understanding, what's the family's understanding, those conversations should ideally take place within the first day or so. So I think there is a lot of guidance, and I suppose the difficulty in a busy hospital setting is trying to keep track of all of that and also keep the patient at the centre. And I think if we treat each patient as we would want to be treated ourselves, or our family member to be treated ourselves and to be communicated with, then it's harder to veer off that difficult path.
Learning disabilities, you know, people with a learning disability used to live in an institution, and it's only in the last 20 years that we've come into the community. And from a learning disability perspective, we've always had to fight for services, the fight to live in the community among other people. So you often find that families and carers, we always feel like we're coming into battle for the rights of people with a learning disability. So after 20 years, to still be feeling like we're fighting for people to have the right to health care or the right to the same service as everyone else, that's why families still do it, because it's been inbred in them since their son or daughter was born, to fight for the rights of their child. So it's upsetting that we're still having to do that when, you know, we're so far on.